Good evening, dear students. As I am looking into the chat, Ranjit Chauhan, Dr. S.G. Omkar, Roshan, Apurv, Lata, Dr. Yash, Rishabh, Sushmita, Mohammed. Good evening to you all. And as you understand, today's session is for your NEET PG exam. And what we do is we have planned 2 days, 2 hours each day, today and tomorrow evening. We'll be trying to go through some of the topics which we feel are important for your next upcoming exam. Try to do some revision which is going to be fast. In between, I'll keep asking some questions and try to answer them as per your best knowledge. What you find is one histology diagram in front of you right now. So let us begin with that itself. Good evening, Pramod, Anu, Tina, Gayatri, Pradeep, Siddiq Khan, Avinash, Anshul, and all of you. So as we look at this diagram, it is one of the histology diagram, and recently you must have noticed some of these H&E type of questions are coming to you. What I am showing here is modification of the surface epithelium, which could be the cilia or which could be microvilli. Sometime you may find keratin, and you should be training your eyes to identify these surface projections. Now let us zoom on to the very first diagram here, and this is the schematic diagram here, and that is the actual H&E stained histology slide. What you notice is that there are some projections which are appearing thread-like processes, and these thread-like processes, they are basically called as the cilia, the surface modification. They will be having some basal bodies, that is the centriole mechanism, and these basal bodies which are made by the centrioles, they will be helping the cilia to move. And two good examples of cilia in our body are, number one, respiratory tract, and number two, the genital tract. Basically the female genital tract, uterine tube. So why do we need these cilia in the respiratory tract? When we are breathing, some of the air is coming, dust is coming, bacteria is coming, and you are trapping that dust and bacteria in mucus. Mucus which is being secreted by the goblet cell in the respiratory epithelium, and the bacteria or the dust which is trapped by the mucus must be coughed out, expulsion, mucociliary clearance. So for that purpose, we'll have cilia in the respiratory tract. What about the genital tract? In genital tract, specifically talking about the female genital tract, in the uterine tube, you will have the cilia. And what is the purpose of having cilia in the uterine tube? To move the conceptus towards the uterine cavity, so that the conceptus is going to implant in the cavity of the uterus. Now there is a problem sometime, what we call as the Carter-Jenner syndrome. And in Carter-Jenner syndrome, it might happen that the cilia is immotile cilia syndrome. Now when there is immotile cilia syndrome, you'll have some features, and in Harrison medicine you will find that it is also mentioned as Carter-Jenner triad. What will you include in the Carter-Jenner triad? Number one, it is chronic sinusitis, because you are unable to clear off the mucus trapping the bacteria and all that. So chronic sinusitis is one of the feature in the triad. Number two, because we are unable to cough out the infective material, there might be infection in the lungs and leading to bronchiectasis. So number one, it is the chronic sinusitis. Number two, it is the bronchiectasis. And number three, there is situs inversus. During development, the embryonal cells, they have cilia and they move here and there to have respective position of the organs. If there is Carter-Jenner syndrome, immotile cilia syndrome, cilia is not moving, embryonal cells, their cilia is not moving, organs will be misplaced. The heart is more towards the right side, that is dextrocardia. Spleen is seen on the right side, a feature of situs inversus. So organs may be misplaced, and that is situs inversus, a feature of Carter-Jenner. Now Carter-Jenner triad, you have three things, but in Carter-Jenner syndrome, you can have 3 plus problems. Now, what is that plus problem? Not to be included in Carter-Jenner triad, but is a feature of Carter-Jenner syndrome, that is reduced fertility. Because the cilia are not moving in a female, the cilia will not be sending the conceptus towards the uterine cavity, and there might be ectopic pregnancies, abnormal implantation, reduced fertility. So that is also one of the feature of Carter-Jenner syndrome, but not a component of Carter-Jenner triad. Questions come like that. And these cilia, as I mentioned, they appear like some thread-like processes having basal bodies. Look at the next slide. As you are looking at the next slide, you'll find that there is again some surface modification, and that surface modification is to be identified by your eyes in the exam, because we have very little time. You see, this time it is some pinkish lines which are moving in longitudinal fashion, and that is what we call as keratin. So as we talk about the keratin, keratin is found on the surfaces of epithelium. For example, stratified squamous epithelium, as you see here, this is a stratified squamous epithelium with keratin, and it is keeping the surface dry. For example, the skin surface, even the surface of the face, even the entry point, lips, even the deeper anterior portion of the tongue, the hard palate. Be careful that anterior portion of tongue and the hard palate are also lined by keratinized stratified squamous epithelium. As you go deeper, means posterior tongue or soft palate, then keratin is lost. So what is the lining epithelium of the anterior tongue and the hard palate? That is stratified squamous epithelium with the keratin. And what about the soft palate or posterior tongue? Then it is non-keratinized stratified squamous epithelium. So just be careful about these examples, and you can also see keratin on the surface. Now I'm going to ask you this. Identify this epithelium which you find in front of you here, and you can mention that in the chat. I'll be looking into the chat now. This epithelium, which is again multi-layered, and usually you will be given this slide. So you have to focus upon this slide. Which epithelium is that? Let me just go through the chat as well. Gag reflex, yes, I will be talking about that, Roshan. Urothelium, fantastic. Yes, right. It is urothelium. When you say it is urothelium, it also means it is urinary epithelium. So we call it as urinary epithelium, or it is called as the urothelium. Here what you find is it is stratified appearance, but the topmost cells are quite larger. As you will notice, this cell is quite big, and it is called as U, umbrella shaped cell. As I draw it, let me draw it here on this side. It is kind of a cell. This is, say, the topmost layer you are looking at. It is a cell which will be having multiple projections like this, can be double nucleated also, 2 nuclei, and it is having this kind of appearance. Large cell towards the lumen, and the basal cells are smaller as compared, and you will see that it is such a large cell that it is actually keeping 4 or 5 cells underneath. So one cell, 4 or 5 cells underneath, like it is like an umbrella. You see, this appears like an umbrella, and under the umbrella you are having few more cells. So umbrella shaped cell. What is the importance of this cell? It has stretchable epithelium. It can stretch. For example, it is present in the urinary bladder, and in the urinary bladder, when there is urine, you have to stretch the epithelium, stretchable epithelium, urothelium, and it is quite a large cell. It can actually still stretch itself. So that kind of appearance. See, the point is, when you find such diagrams, you have to identify them quickly, and you see this is one nucleus, let us use this color, another nucleus, but the topmost cells are quite large cells. Cells are basically identified by looking at their nuclei, but quite large cells towards the lumen side, because this is obviously here, as you see, will be the basement membrane. This is the basement membrane. Towards the lumen side, a large cell, stratified appearance, is that of urothelium. Where do you find urothelium? Urothelium is actually beginning at the tip of collecting ducts, and after that, as you proceed further, in the kidney there will be collecting ducts. So at the tip of collecting ducts, then it will be in the minor, major calyx, renal pelvis, ureter, urinary bladder, and proximal portion of the prostatic urethra in male, and in female just you can say proximal urethra. So we can draw a diagram also for the same purpose. Where do you find urinary epithelium or transitional epithelium? That comes as a question, and what we do is we are mentioning this is the kidney. In the kidney you have collecting tubules. So these are the collecting tubules, and if you're looking at the tip of collecting tubule, you will find that at the tip of collecting tubule there will be transitional epithelium. Transitional epithelium is not lining the collecting tubule, only the tip will be having transitional epithelium. Now if only the tip is having transitional epithelium, there can be a question which will ask you, what is collecting tubule lined by? Or it is better called as collecting ducts. So what are the collecting ducts lined by? Collecting ducts have double epithelium, but chiefly it will be what you call as, we can mention here, the columnar epithelium. It is columnar epithelium and simple columnar epithelium. Most of the collecting ducts are lined by simple columnar epithelium except the tip, because tip has transitional epithelium. So transitional epithelium, which is stretchable epithelium, begins at the tip of collecting ducts, then where it is proceeding. After that you can mention from the collecting ducts, as we proceed further, it can be seen in the minor calyx, major calyx, minor calyx, major calyx, and after that renal pelvis, the kidney, renal pelvis, and after renal pelvis the ureter, and after ureter it is also in the urinary bladder, and after urinary bladder in the proximal prostatic urethra, proximal prostatic urethra. So where all do you have transitional epithelium? It is at the tip of collecting ducts, then minor calyx, major calyx, renal pelvis, the ureter, urinary bladder, and proximal prostatic urethra. In a female you can just say proximal urethra in the female will have transitional epithelium. After that the epithelium changes actually. Now as we continue with our discussion here, what about this diagram here? As you see, let me use, because it is now crowded, so let us use this one. What about this epithelium now? As you see, this epithelium, this is schematic diagram, that is the actual diagram. Train your eyes to identify this type of surface modification. And what is that surface modification? You will notice that there is a thin pinkish line which is not very much high as was cilia. It is not that height of cilia, it is microvilli. This is microvilli. It gives you pinkish appearance. Let me rub it off so that you can have a good idea that how it will appear. So what is this epithelium? This epithelium, where you see the microvilli, the surface modifications to increase the surface area of absorption, can be seen in the intestine. So in the small intestine you will have the striated border, and that striated border is basically the microvilli to increase the surface area of absorption. Now there is a difference between striated border and brush border. Brush border you will find it is found in the proximal convoluted tubule of the kidney. So can you tell me what is the difference? In the chat you can mention what is the difference between microvilli which we find in the small intestine and the microvilli which we find in the kidney proximal convoluted tubule. One is brush border and the other is मोहम्मद शमशाद, सर ओनली बायोलॉजी एमसीक्यू करके नीट क्लियर क्वालिफाई कर सकता हूँ। कौन सा नीट? आप नीट पीजी की बात कर रहे हैं? बायोलॉजी लिख रहे हो तो नीट यूजी की बात कर रहे होगे। बायोलॉजी टर्म जो यूज़ होती है वो नीट यूजी के लिए होती है। नीट पीजी में बायोलॉजी नहीं यूज़ करते, उसमें ह्यूमन बायोलॉजी कहते हैं, बल्कि उसके बाद उसकी एनाटॉमी बन जाती है। वीडियो इज़ नॉट क्लियर, कांट सी प्रॉपरली। क्या चीज़ क्लियर नहीं है भाई? ये तो फोटोग्राफर जो कैमरा सेट कर रहे हैं वो बताएंगे। भाई मोहम्मद शमशाद, ये ओनली बायोलॉजी एमसीक्यू करके नीट क्वालिफाई कर सकता हूँ, मतलब ये सवाल किसके लिए है? प्री मेडिकल टेस्ट के लिए है क्या? अगर प्री मेडिकल टेस्ट के लिए है तो पीसीबी होता है, फिजिक्स होती है, केमिस्ट्री होती है, बायोलॉजी होती है, बायोलॉजी में भी फिर बॉटनी और जूलॉजी होती है। तो अगर नीट यूजी की बात कर रहे हो तो फिजिक्स, केमिस्ट्री, बायोलॉजी, बायोलॉजी में बॉटनी और फिर जूलॉजी। जूलॉजी का एक कंपोनेंट हम पढ़ाते हैं ह्यूमन बायोलॉजी, तो हम तो बहुत ही लिमिटेड पढ़ाते हैं फिर उस हिसाब से आपको। अच्छा चलो कोई बात नहीं। माइक्रोविल्लाई इन जीआईटी, चलो मैं आपसे क्वेश्चन पूछा था उसकी बात बताइए कि ये जो माइक्रोविल्लाई है यहाँ पर, इसका जो अरेंजमेंट है स्मॉल इंटेस्टाइन में स्ट्राइटेड बॉर्डर है जो कि आपको यहाँ नज़र आ रहा है। तो ये पीसीटी में ब्रश बॉर्डर क्या फ़र्क होता है? फ़र्क ये होता है कि अगर आपने इसे देखा यहाँ स्मॉल इंटेस्टाइन में, तो माइक्रोविल्लाई का साइज जो है वो सेम होता है, यूनिफॉर्म हाइट होगी। जबकि अगर आप बात कर रहे हो पीसीटी की तो एक माइक्रोविल्लाई छोटा है, एक लंबा है, एक छोटा है, एक लंबा है, तो हाइट में डिफरेंस होता है। इफ देयर इज इक्वल हाइट ऑफ माइक्रोविल्लाई यू कॉल इट स्ट्राइटेड। स्ट्राइटेड इज प्रेजेंट इन स्मॉल इंटेस्टाइन एज यू सी हियर एंड इट इज अ सिंपल कॉलमनार एपिथेलियम विच इज स्ट्राइटेड बॉर्डर। पीसीटी में वो क्यूबॉइडल होता है और ब्रश बॉर्डर होता है। सो क्यूबॉइडल एपिथेलियम होगा और माइक्रोविल्लाई होंगे टू इंक्रीज द सरफेस एरिया ऑफ एब्जॉर्प्शन, क्योंकि पीसीटी जो है वो 75% ऑफ यूरिन से जो कंपोनेंट है उनको एब्जॉर्ब कर रहा होता है, नीड्स लॉट ऑफ एब्जॉर्प्शन कैपेबिलिटी। सो द क्यूबॉइडल एपिथेलियम विद the microvilli, but they are unequal height, so it is called brush borders. So just be careful about that. So Mohan Priya is asking, sir, English please. I usually teach in English, but when there are some people who are also speaking in Hindi, so sometime I use Hindi as well, okay? No issues. Usually I teach in English. What does PrepLadder Marathon offer in contrast to rapid revision in the app? Rapid revision in still more rapid fashion. That is your marathon. Actually, rapid revision means you will be revising almost adequate amount of anatomy. See, you can yourself understand. Rapid revision in anatomy is for 20 hours and marathon is total 2 plus 2, 4 hours. So in 4 hours, what I can cover, compare it with something which I can cover in 20 hours. Plus, in marathon, I am interacting with you. In rapid revision, there is no interaction. So if you compare the content, it will be 10 times more in rapid revision and reduced in your interactive sessions. That is what I can mention. कोई बोलता है हिंदी बोलो, कोई बोलता है हिंदी मत बोलो, तो ये दो सेशन होने चाहिए, एक हिंदी में होना चाहिए और एक इंग्लिश में होना चाहिए. When it started, भाई अभी बस थोड़े समय की पहले की बात है, 20 मिनट हुए केवल. Anyway, so let us continue. Now the next thing is, you are getting some questions which are based upon such diagrams. What you notice here is they have put a star mark, and what is the star mark for? You will appreciate that it is one receptor at the dermo-epidermal junction. This is epidermis here, and as you can see, it is stratified squamous epithelium. The basal cells are columnar, then cuboidal, and the superficial cells are squamous. So it is stratified squamous epithelium, and that is basically epidermis. This is dermis. Dermis means it will be sub-epithelial connective tissue, and which is also called as lamina propria. You can say this is the lamina propria. So lamina propria, or the subepithelial connective tissue, at the junction of the epithelium and the dermis, dermoepidermal junction, this is what you call as Meissner corpuscle. Now when you are talking about the Meissner corpuscle, tell some feature of Meissner corpuscle. Meissner corpuscle is rapidly adapting receptor. These are all MCQs. They are all MCQs and they are repetitively asked, so you should remember them quite well. First of all, its location, dermoepidermal junction. Number two, what you have to remember is that it is rapidly adapting. And as it is rapidly adapting, it is basically detecting the fine touch. And fine touch is important for 2-point discrimination. 2-point discrimination. So a question comes, which receptor is helping us in 2-point discrimination, the one which will help us in carrying the fine touch? That is the Meissner corpuscle. It is also helping us to, it is basically helping us to have this touch sensation. Of course, that is how you do this 2-point discrimination, touch sensation, plus vibration also. Now the question will ask you which type of vibration. Is it high frequency or low frequency vibration? If it is the Meissner corpuscle, it is for low frequency vibration. Low frequency vibration, because if it is high frequency vibration, then you have to go still deeper in the deep dermis and you have Pacinian corpuscle. So deep dermis, Pacinian corpuscle is for pressure and vibration, and that pressure and vibration, that vibration is high frequency vibration. If you say Meissner corpuscle, it is for low frequency vibration and tactile discrimination. Now a question comes, it will ask which receptor you use for reading Braille. Which receptor you use for reading Braille? Your answer is Meissner corpuscle. So Meissner corpuscle is helping us in reading Braille. Another question comes, it will ask you which is the best receptor to read Braille. Then you cannot answer this. Which one will you answer then? There are two questions. Question number one, which receptor is used for reading Braille? Your answer is Meissner corpuscle. Question number two, which is the best receptor for reading Braille? Then the answer is not Meissner corpuscle. Then what is the answer? The question I'll mention and then I'll mention the answer. Question is best receptor for reading Braille. Then you have to answer it as Merkel receptor. And where is Merkel receptor? Merkel receptor is at the basal layer of the epithelium, which is also called stratum germinativum, or it is the stratum basal. The germinativum, the basal layer where you have columnar cells, there you will have some Merkel receptor. What is the purpose of Merkel receptor again? Touch. If it is touch, which kind of touch are you talking about? Holding a pen. It is detecting this holding the pen and it is slowly adapting. So Merkel is slowly adapting first of all, because Meissner is rapidly adapting. Meissner is rapidly adapting, whereas Merkel is slowly adapting, and Merkel is the best receptor to read Braille. If Merkel is the best receptor to read Braille, then why are you mentioning that we are using the Meissner corpuscle for reading Braille? Because you have to understand, if you want to detect the character of Braille, the best receptor is definitely the Merkel, but it is very slow. And it can help you to read the words, the letters, but it cannot actually help you read the sentences. See, what is Braille? Braille is like you want to tell a story to a blind person, and that story is a long story, so you have to read very fast. Maybe the Meissner corpuscle is not the best receptor to reading Braille, but it is the one which help you read the sentences, the stories. Maybe the best receptor is the Merkel, but Merkel cannot help you reading sentences fast. It can help you reading CAT, cat, IS is, sitting there, SITTING, THERE, that much it can read. But is that how you read Braille? Do you read words or sentences? What you read is, the cat is sitting there, the cat is sitting there. Which receptor helped you reading? The cat is sitting there. Meissner. So I'll repeat again. Question number 1. Which receptor we use for reading Braille? Meissner. Which is the best receptor to read Braille? Merkel receptor. So just understand the difference. I hope this will help you in solving a controversy, because it is a controversy, and not many faculty, what they do is they just try to escape the controversy. They'll just tell something and confirm it, and this is the answer, but that is not the way to teach. You should understand what the examiner is trying to ask, and accordingly you have to give your answers. There is on particular question having a different answer, another question having different answer. You are a good teacher only if you can differentiate between the two questions and give different answer and also justify it. Otherwise, this is a competitive exam. It is any teacher who says that NEET PG exam or INI-CET exam is very easy, very simple questions are asked, I disagree with them. It is not. It is not an easy exam. It is very much specific, precise exam, and you must have precise data, and questions are very deep. They are not superficial questions. Cannot be answered by just reading Guyton or just Gray's Anatomy. You need to work. Lot of hard work is required. Take it from me, because I observed this system for last 21 years, and I am very sure that the examiner who was asking such questions, there are two different questions, they'll have two different answers. Take it from me. Okay, what are you looking at right now? Tell me. How many questions of anatomy in NEET PG? At least 20 questions which are pure anatomy, and 10 more which is interdisciplinary. Sometimes ENT people are asking ENT anatomy, but it is anatomy which I teach. Orthopedics, teacher is asking some anatomy, but it is eventually it is anatomy. It is not pure orthopedics. So 20 plus 10, 30 questions in total. Okay, so we continue, and let me just see. Will the whole pattern change in next from NEET PG? I teach for next PG for last 20 years. The way I teach is the way next PG is going to ask. What is next PG going to do? It is going to ask you anatomy which is clinically related, and that is how I teach. Nothing is going to change in anatomy, at least. I have been teaching the same way, I will keep teaching the same way, you'll keep getting the same type of questions. Though in NEET PG, especially if it is conducted by DNB people, they can ask you very simple questions, rote memory questions. Maybe those rote memory questions will disappear, and which is a good thing. You should not be giving somebody rank by just depending upon their rote memory. Rote memory is good, but you should be asking questions which are clinically relevant. Like, I'm asking you one question which is based upon rote memory. What is this? What do you think? Cerebellum removed, yes. Floor of fourth ventricle. So that is a rote memory question. Now I'll ask you a clinical question and try to answer. That is next PG. Now, as you see here, let us first try to identify the structures. What do you think is this? What do you think is this here? This is the pineal gland. If that is pineal gland, then what is this structure here? And what is this structure here? Together they are called as corpora quadriga minor, and this is superior colliculus, this is inferior colliculus. You can remember that the eyes are above and ears are below. Superior colliculus is helping us in the visual pathways, and inferior colliculus help us in the auditory pathways. So inferior colliculus for auditory pathway, if you remember auditory pathway will have the mnemonic. What is the mnemonic for auditory pathway? This question keep coming all the time. So I am telling that eyes are above, superior colliculus works for them. Ears are comparatively below, inferior colliculus work for auditory pathway. The auditory pathway, you can remember, is slim, 41, 42. Now when you say slim 41, 42, this I is the inferior colliculus. I is the inferior colliculus. Can you tell me what is this S for? That S is basically the superior olivary nucleus. Now if S is the superior olivary nucleus, then what is L for? Lateral lemniscus and the brainstem. If lateral lemniscus in the brainstem, I is the inferior colliculus. You mean to say inferior colliculus would have received the information from the lateral lemniscus. What is a lemniscus? Lemniscus is bundle of axons carrying some information. If running laterally or medially, there can be medial lemniscus, there can be lateral lemniscus. So this is lateral lemniscus. So if the auditory pathway is slim 41, 42, S is superior olivary nucleus in the brainstem, the L is lateral lemniscus, I is inferior colliculus. What is M for? M is the medial geniculate body, which is metathalamus. So medial geniculate body, metathalamus. After that, the information will go towards the cerebrum, and area number 41, 42, superior temporal gyrus. So deep to ear, you have temporal lobe, superior temporal gyrus, area number 41, 42. So that is the sequence you have to remember for your auditory pathway. In the auditory pathway, inferior colliculus will come. Now you see some more details here. Tell me which peduncle is this, and then let me change the color. We will also look at this peduncle. This is one peduncle because it is cerebellum we have removed, so cerebellar peduncle. One of that is superior, this is the middle, and then what is left here, say this one, will be the inferior. If you say middle cerebellar peduncle, if you are talking about the middle cerebellar peduncle, it is mostly incoming fibers, cerebro-ponto-cerebellar fibers. So from the cerebrum, the fibers will come to pons, and from the pons it will go to cerebellum, the CPC fibers. What is CPC fiber? Cerebro-ponto-cerebellar fibers. That means middle peduncle is mostly incoming or afferent fibers. Afferent means arrival, incoming, afferent fibers. Whereas the inferior cerebellar peduncle, if you focus upon inferior cerebellar peduncle, it is mostly efferent. Efferent means, this superior cerebellar peduncle is efferent. Efferent means exit, the outgoing. If you are talking about the inferior, it is also mostly afferent. Here it is afferent. Afferent means arrival. So my point is, in the middle peduncle, mostly it is incoming fiber, arrival or afferent fibers, A for arrival, A for afferent. Even inferior cerebellar peduncle, mostly it is incoming fibers, arrival, afferent fibers. But if you are talking about superior cerebellar peduncle, it is exit, efferent, E for exit, E for efferent. Which fiber are you talking about? In superior cerebellar peduncle, which is outgoing from the cerebellum. This is all in relation with the cerebellum. That is the pathway which we were talking about, dentato-rubro-thalamic tract. This is thalamus here. You are looking at thalamus here. So this pathway, as you see, it is dentato from the dentate nucleus will come, dentato rubro-thalamic tract, because that is thalamus. So where is this rubro, red nucleus? Red nucleus is actually at this level. You can show in red color itself, at the level of superior colliculus. At the level of superior colliculus, if you take a section of the midbrain, the superior inferior colliculi, they are in the midbrain. So at the level of superior colliculus, you will have red nucleus. Though it is understood, dentate nucleus in the cerebellum mostly send fibers to thalamus. You should call it as dentatothalamic tract. But some fibers also terminate in the red nucleus. So you are telling dentato-rubro-thalamic tract. Where the decussation happens, that is the question. And you should say the decussation, which you can find here at this moment, let me mark here, it is decussating at the level of inferior colliculus or below inferior colliculus. Actually, it can be mentioned as the junction of the pons and midbrain. So wherever you have the junction of the pons and the midbrain, at the level of inferior colliculus, that decussation is happening. So what is the importance of knowing that? Importance of knowing that is, if I have a midbrain lesion on the, say this is posterior view, so left side, because you're looking from posterior view, the left side, if there is a left-sided midbrain lesion, where is the problem of coordination will come? Because what is the function of dentate nucleus in cerebellum? Dentate nucleus in cerebellum is for coordination of voluntary motor activity, skeletal muscle activity. Like you are writing with pen. When you write with a pen, you need coordination, and that coordination is controlled by dentate nucleus. So dentato-rubro-thalamic tract, if it is compromised from the posterior view, this is left side, on the left side of the midbrain, which hand will have the problem? The hand which will have the problem is obviously right hand, because the fibers were crossed. So a lesion on the left side and ataxia, cerebellar ataxia will come where? Cerebellar ataxia will come on the right side, contralateral, because this lesion is after the crossing of fibers. So this is the next PG question. What is NEET PG asking? Though these days NEET PG is also asking clinical questions, but NEET PG can ask you simply, which peduncle is this? But next PG will ask you, what if there is a lesion in the midbrain at the level of superior colliculus, where will be difficulty in coordination, right side, left side? That kind of questions can come. So that is the difference in the two type of exams. Now there is one other question which came. Let me show it here at the floor of the fourth ventricle, because what you see now is basically here the fourth ventricle. This is the fourth ventricle. So there was a question at the floor of the fourth ventricle. There is a rounded elevation, and what will happen if there is a lesion of this rounded elevation? So NEET PG question will be, facial colliculus is produced by, and you will say facial colliculus is produced by the axons of facial nerve. That is why it is called as facial colliculus. Next question, which nucleus is deep to facial colliculus? Then you will say the nucleus which is deep to facial colliculus is abducens nucleus, the sixth nerve nucleus. So next question will be, is the abducens nucleus producing the facial colliculus? No. The abducens nucleus lie deep to facial colliculus but does not produce the elevation. What is colliculus? Superior colliculus, inferior colliculus, facial colliculus, a rounded elevation. And that rounded elevation is not produced by abducens nucleus. It is produced by the axons of facial nerve. Now, if it is produced by the axons of facial nerve, a question came, what will happen if there is a facial colliculus injury? If there is a facial colliculus injury, two nerves will be affected, the axons of facial nerve and nucleus of the abducens nerve. Question was asking, if there is a facial colliculus injury, which muscle will be paralyzed? And the options are risorius will be paralyzed, or the lateral rectus, which is supplied by abducens nucleus, is paralyzed. You say both. But you cannot have both answers. Which is your first answer, the most appropriate answer? Question is, when there is a injury of facial calculus, which nerve is involved? Facial nerve. So which muscle will be? First answer. Rhizolius is a better answer than lateral rectus. So that kind of questions keep coming. Okay, now as we proceed further, I have got this diagram here. Tell me which kind of hematoma is this, because they are again frequently asked questions. We are going to look at some of the questions which I think will be appearing again in your NEET PG, in the coming NEET PG. Auditory pathway is a very frequently asked question. Rahul is asking, stuck at the same level in every GT, how to improve despite every effort we can do? See Rahul, if you are stuck at the same level, you have to understand that GT is again a competitive exam and it is cutthroat exam. If you are improving at the same speed, the other people are also improving. That is why you are stuck at the same level. Say for example, you are driving a car and you want to improve, means you want to leave other people behind. Now, if you increase your speed, the other fellow is also increasing speed. So you are in the same place. You have to still more push yourself, push your boundaries. It is just like a car race. If you want to win, you have to be the topper. At least try to be the topper. You have to leave these people behind. In GT, you are not improving because you are not pushing hard. We have to be very serious about life. I'll give you one simple story here, one short story. One Guruji and one Shishya, one teacher and one student walking along the riverside. And like you and me, the student is asking, sir, I want to get a PG seat. I want to get a best rank in GT, but I'm not getting it. So what to do? And I'm asking the person, do you really want to get a good rank in GT? Do you really want to get a PG seat? And this small student is answering, yes sir, I want to get the best rank in GT, I want to get a PG seat. Are you sure about this? Because it will take a lot of efforts. And the student is telling, yes sir, I'm ready for that. And what the teacher does is, takes the student and starts walking into the river. Deeper, deeper into the river. At one particular level, because teacher is taller, student is shorter, the water is overhead. And now the student starts struggling because he cannot breathe. But this teacher doesn't allow him to come up. And he is struggling and he doesn't allow him to come up. And then after some time, he brings him back to the edge of the river. The student is totally shocked and he is just trying to be comfortable. He is also making him comfortable, the teacher. And the teacher is asking him one question. What was the thing you wanted when you were about to drown and you knew that death is around me? What was the only thing you wanted? And the student is thinking slightly and he replies back, the only thing I wanted was some air to breathe in. And then the teacher replies, the moment in your life when you will find that kind of desire which you were having for oxygen, for your GT or for your PG seat, that moment you will get your seat. That desire, that burning desire. When there is nothing left, there is only one thing left, focus. You must have seen me telling you, Arjun never missed his arrow. Why? Because he was looking into the eye of the bird. He couldn't even see the bird, the tree or the sky. That sharp focus, that is what I can tell you. Okay. Right? Should I give daily GTs? Why should you give daily GTs? You should give GT maybe once in a month or maybe once in 15 days. See, I am always serious about life. I am always serious about my teaching. I am always serious about you people getting a seat. I am a very serious man as such. That is why you might have seen I rarely smile while teaching. Because life is not easy. Life is difficult. I really dislike those teachers who come in front of you and tell, this is very simple thing. What is there? Everything is so simple. Life is so simple. It is simple for you, 1% of the people who are in the top notch of the society. You can say that. There is another story. I think a very famous person said, money is not everything. You should speak such nonsense only when you have good amount of money in your account. I'll repeat it. Money is not everything should be spoken, such nonsense should be spoken by a person who has ample amount of funds in his account. So these are 1%, top 1% top-notch people who speak all nonsense. This is not easy. Who says this is easy? And if it is easy, everybody should get a PG rank. Why not everybody is getting PG rank? Don't take it easy. Life is not easy. It is cutthroat competition. Take it from me. So tell me, what do you see here? So what you see here is a CT scan, and this is the skull on the periphery. You can say this is the bone, and this is the brain tissue. This is the ventricle. See, one of the ventricle is compressed here, some space occupying lesion, and that space occupying lesion is actually intracerebral hemorrhage. Now, if you say it is intracerebral hemorrhage, it is appearing bright white. So, if it is bright white, that means it is acute. Maybe within 2-3 days you have taken the CT scan. If it becomes darker, then it will be, maybe after a week you have taken the CT scan. So, early CT scan, early bleed will appear white, otherwise it will become darker. Sometimes it can be as darker as CSF. You see, the CSF is quite dark, and even the hematoma can be as dark as the CSF is appearing if it was a chronic hematoma, but this is acute hematoma. Now my question to you is, when there is intracerebral bleed or it is the intraparenchymal bleed, it can be happening in hypertensive patients. In hypertensive patients, there was a question, it was asked, mostly they are Charcot-Bouchard aneurysms which are bleeding. Charcot-Bouchard aneurysms which are bleeding. Now it is a controversial question. Charcot's artery supplies which limb of internal capsule? This question has come recently. So intracerebral hemorrhages can be due to, they can be in hypertensive patients, can be bleed of this Charcot-Bouchard microaneurysms, which are basically, to supply the internal capsule, and the lenticular nucleus, corpus striatum of basal ganglia. They are called as lenticulo-striate branches of middle cerebral artery. So middle cerebral artery, which supply the cerebrum, also is giving lenticulo-striate branches. Lenticulo means lenticular nucleus, part of basal ganglia. Striate branches means striatum. Caudate and putamen is striatum. So lenticulo-striate branches of middle cerebral artery is basically giving Charcot's artery. So Charcot's artery, which is given by middle cerebral artery, is supplying which limb of internal capsule? Actually, if you read Indian authors like Bedi Chaurasia or Visham Singh, they'll say posterior limb of internal capsule. So maybe we can remember it as posterior limb of internal capsule. What will happen if the posterior limb of internal capsule is compromised? What kind of clinical presentation will be there? So posterior limb of internal capsule has been compromised because the Charcot's artery has been compromised. So what will be the clinical features? Because in the posterior limb of internal capsule you have sensory motor fibers below the head region, because head sensory motor fibers pass in the genu having separate arterial supply. The sensory motor fibers of head are passing in genu, which is separate arterial supply, but for upper limb or the trunk region, lower limb, all the fibers pass in the posterior limb of internal capsule. So if one-sided posterior limb of internal capsule has been compromised, there will be contralateral. If it is right-sided posterior limb of internal capsule compromised, problem will be on the right side, on the left side, contralateral. Upper limb will have spastic palsy, lower limb will have spastic palsy, and there will be loss of sensations on this side, contralateral hemiplegia and hemiparesis. So these are some of the clinical implications which we are talking about. Now this you have identified, this is intracerebral lesion, fine. What about this diagram? What is this? Because these are the questions which are appearing, and they are not only, see, what do you think this question belongs to? Medicine, surgery, radiology, anatomy? Which department is giving this question? Can you tell me? Can you tell me which department is giving this question? Is it a radiology question or surgery question? Is it an anatomy question? You cannot stop WhatsApp actually, because I am having this session on my phone. Maybe I have to devise some method. But anyway, so unnecessary distraction basically. Anyway, so what do you think is the answer to this question? First of all, it can be asked by anybody. It can be an anatomy person also asking such a question, but mostly it is anatomy and radiology people sitting together. They'll be asking a question, or maybe it is anatomy plus surgery people sitting. It is interdisciplinary. This is next. So when you are talking about next exam, it will be surgery and allied subjects, medicine and allied subjects. What is surgery and allied subjects? Why they are not asking you orthopedics in your next exam? Do you really think they are not asking you orthopedics in your NEET PG? They will be asking, but it is surgery and allied. Will they not ask you anesthesia? Will they not ask you physical and medical rehabilitation? They are allied subjects, okay. So tell me, can you see this darker color here? And this is some lighter color here. And this is a lunate shape hematoma. First of all, it is concavo-convex, so immediately you will say subdural hematoma. Subdural hematoma. And take it from me, it is also medicine question. In Harrison medicine, you'll find. In substance surgery, you'll find it. In Sutton radiology, you'll find it. You'll find it in Gray's anatomy also. Which department does this question belong to? It is interdisciplinary. So this is subdural hematoma because it is lunate shape or convexo-concave. Now as I mentioned, it is bright white, so acute, and this is dark, just the same appearance as CSF, so in the ventricle. So it is basically chronic. You can say this is a chronic subdural hematoma on which you have acute. So acute bleed on a chronic subdural hematoma. Can you tell me the age group of such patient? Age group. Now I understand you will immediately tell me it is elderly, but not necessarily. It is elderly. You will say mostly they are alcoholic patient, but not necessarily they are alcoholic patient. And that is the problem. You see, once the examiner knows that you know the answer, he'll dig deeper. And you are bound to make mistake because teachers teach you very superficially and you learn very superficially. But the examiner can also ask superficially, but he has to screen 5,000 students out of 1 lakh student. There are 1 lakh students sitting and he has to screen 5,000 out of that. So he'll go into deeper aspect. Remember, maybe you have been taught that the subdural hematoma is mostly chronic, but it can be acute also. If it is acute, see, these will be chronic. They will be presenting with chronic subdural hematoma. What if it is acute subdural hematoma? There can be a possibility, and these patients, they can be a child, battered child syndrome, or a young person riding a car having a head-on collision, coupe contra coupe injury. So this can be acute subdural hematoma, and acute subdural hematoma can be a child, battered child, shaking the child like this. Why did you cry? Why I gave you milk, you are still crying? Some mothers are like that, young age mothers basically. So that is why you should not have kids before you are mature enough to have a kid. And acute subdural hemorrhage can also be a young person who is driving a car and having a coupe contra coupe injury. So then it will be bright white. Now, what is the purpose of telling you this? Maybe you are very comfortable. I can identify this diagram very well. But next time this question will not come. Next time they will change the history and you will be confused. So that is where next pattern means you should have ample good knowledge and you should have read from good books, or at least some good teacher should have taught you. That's the only purpose I'm trying to make sure. Will they have lucid interval? Will they have lucid interval? Lucid interval, normally we say it will be in extradural hemorrhage, but even these people can have lucid interval. What is lucid interval? Lucid interval is you have some trauma, there is loss of consciousness, you regain the consciousness, there is a duration of consciousness, and again you lose consciousness because the hematoma is becoming larger and that compresses the brain and again. So lucid interval is basically the duration between LOC1, loss of consciousness 1, LOC2, loss of consciousness 2. Between the two, there is a period of consciousness, that is lucid interval, and can be seen even in subdural hematoma. So what is the purpose of telling you all this? You have to go deeper now. They are frequently asked questions. Now they are going to change the pattern of question and you will be very confidently answering it wrong. Be careful. Now, if you look at this, tell me which hematoma is this? I'll look into the chat. Let me see. How many of you identify? Is it only EDH, extradural hemorrhage? Can you see? Examiners can trick you into wrong answers. Be careful. Of course, you are correct. This is, some faculty will tell idli shape. So if it is idli shape, it is extradural hemorrhage, yes. Biconvex lentiform, you can say biconvex lentiform extradural hemorrhage, yes it is. But do you notice here something? What is this? This is not only extradural hemorrhage, but this is also subdural hemorrhage, and both are acute. Both are acute. Whitish. So, extradural hemorrhage, a question comes, happening in which kind of patient? Now, normally what we teach is there'll be a fracture at the pterion. Some young man is driving a bike without helmet. That is the usual history we give. Young man riding a bike without helmet falls down. There's a fracture at pterion and one artery is bleeding, which is anterior division of middle meningeal artery deep to pterion. So he will have extradural hemorrhage. But is that the only clinical history you get these patients? There can be other cases also where you can have extradural hemorrhages. It can be trivial injury only. Very trivial fall can also give you extradural hemorrhage. So my point is, don't just depend upon limited source of information which you are having. Once a topic has been coming for last 3 years, last 4 years. If a topic is coming for last 4 years, you cannot depend upon the information which the teacher is giving you or which your notebooks are having. You have to read your Harrison medicine also. But limited topics. And which topics? The topics which are highly repetitive, because I'm sure you are giving some wrong answers. That is why they are repeated. Once the examiner is getting good, correct answers, he will either go into more depth or he'll stop asking the topic. And if you are continuously giving wrong answers, he'll continue asking the question. So it is evident that if a topic is repeated very often, that means most of you are giving wrong answers. Be careful. So there are some topics which you have to read from good books like Harrison Medicine. You cannot depend upon us. We teach you only very superficial things. Take it from me. Because obviously I cannot teach you Harrison Medicine in a short duration. So I have to squeeze information and make it very simple and lucid, which is wrong thing, of course. Okay, so this is what I just wanted you to be comfortable with. What is this? Which kind of hematoma? Now, obviously, you will be able to identify it, no issue, because you see, your teachers would have told you the star shape appearance comes if it is subarachnoid hemorrhage. Now, this subarachnoid hemorrhage is, again, most of us will think that subarachnoid hemorrhage is due to rupture of Berry aneurysm. Is that so? Is it always due to rupture of Berry aneurysm? There are other clinical scenarios also where you can have the subarachnoid hemorrhage, not necessarily rupture of Berry aneurysm. And then of course you have this thunderclap headache, the headache which I never felt ever in my life, so severe headache. This is basically the subarachnoid hemorrhage, means the vessels which are bleeding. Like if we are talking about Berry aneurysm, anterior communicating artery. Anterior communicating artery, where it begins, because anterior cerebral artery will give you anterior communicating artery. Wherever the branching is given, there is a saccular aneurysm or Berry aneurysm that bleeds. That blood will be actually in the subarachnoid space, basically mixing with CSF, and that is why when you do lumbar puncture, in the lumbar puncture you will have blood or at least xanthochromia, because blood in CSF. So that is basically the CSF which was moving into Sylvian fissure. This is what you call as Sylvian fissure or the lateral sulcus on the cerebrum. So the CSF is filled with blood, and that blood is moving into Sylvian fissure or lateral sulcus of the brain. This is the brainstem here, and in front of brainstem you have that basal cistern or the space filled with CSF. Not only in front of the brainstem but also on the side of the brainstem the blood is going. That is why this star-shaped structure appearing. And of course this is a case of subarachnoid hemorrhage. So frequently asked questions, but my point is just you need to go deeper into these things. Now here, what do you think is this section taken from? Identify what are you looking at. Tell me. Yes, it is spinal cord. Now, if you say it is spinal cord, tell me these anterior horn cells which control skeletal muscles, these anterior horn cells which control skeletal muscles, which are compromised in poliovirus. Poliovirus will compromise the anterior horn cell. What will be the presentation? Say it is the root value, let me just shift it to this side. Say root value L45 S1, which is superior gluteal nerve, has been compromised. Lumbosacral. So there is a poliovirus. Poliovirus is affecting anterior horn cells which control skeletal muscles, and the anterior horn cells at the spinal cord level, L45 S1, lumbar 45, sacral 1, lumbosacral region, root value of superior gluteal nerve have been compromised. Which three muscles it is supplying? They will have flaccid paralysis. So this is what you call as next type of question, interdisciplinary question. What do you think? Were they not asking you this question in NEET PG? In NEET PG they are coming. Actually they used to come to us 20 years back when I myself gave my All India PG. My All India PG exam, my AIMS exam. In my AIMS exam, they used to ask this kind of question. Then the standard deteriorated once the DNB came into picture, Diplomat National Board conducting All India PG. The standard deteriorated. Now the standard is going back to its original. 20 साल बाद. ये कोई नई चीज थोड़ी नहीं है. It is nothing new. This is how I have taught for last 21 years. There is nothing new in this. So tell me, what are the three muscles supplied by superior gluteal nerve? You already know gluteus medius, gluteus minimus, and tensor fascia lata. So flaccid paralysis. Why would it be flaccid paralysis? Tell me. Because these are lower motor neurons. Now if these are lower motor neurons, what do? They control the skeletal muscle, give acetylcholine to skeletal muscle, then skeletal muscle will work. If anterior horn cells are not working, then they will not give you acetylcholine to skeletal muscle. So skeletal muscle will become flaccid, hypotonia. It is hypotonia. The tone will go down. Now what is the role of UMN fibers on this element fibers? Like cerebrum has upper motor neurons and cerebrum on the other side. Let us put the pathway now. Cerebrum on the other side, which is having upper motor neuron, because this is the midline of the body. Say this is the midline of the body. This is right side, let us assume this is left side. So we have taken a transverse section of spinal cord. This is right side, that is left side. And the left cerebrum has upper motor neurons. Corticospinal tract, where do they decussate? Lower medulla. Lower medulla decussation and then synapsing on anterior horn cell. So that corticospinal tract which has crossed is coming, and it is here, somewhere located here. What is the role of this upper motor neuron fibers on the lower motor neuron fibers? Normally upper motor neuron fibers, they synapse on the lower motor neurons, and they are plus and they are minus. Means stimulatory as well as inhibitory. That means modulatory. So they are basically modulatory. They modulate. First, the upper motor neuron on this side will activate the lower motor neuron on the other side. And once they are more activated, then they will inhibit it. So stimulation, inhibition, modulation, so that there is not much of activity. Now the thing is, when they ask you Brown-Séquard syndrome, when they are asking you Brown-Séquard syndrome, this all is compromised. In Brown-Séquard syndrome, there is a person on bike and falling, road traffic accident, some sharp object, half of the spinal cord is gone. Motorcyclist falling down, road traffic accident, sharp object, half of the spinal cord is gone, hemisection of spinal cord, Brown-Séquard syndrome. what will be the features in the patient? Say it was T10 spinal segment which has been compromised. T10 spinal segment which has been compromised. So at the T10, what will be the status of the skeletal muscles? Will they be flaccid or will they be spastic? What will be they? See, the problem of Brown-Séquard quad, if it is at the level of lesion T10, then you will find that the muscles will be flaccid. At T10 they will be flaccid, but the muscles which are below that, T11, 12, L1, 2, S1, 2, they will all be in spastic paralysis. They'll all be in spastic paralysis. Why they'll be in spastic paralysis below the level of lesion? At the level of lesion, T10 muscles will be flaccid, but why T11, 12? Because you have damage, not only this fiber to the lower motor neuron at T10, you have damaged millions of fibers which were supposed to modulate still lower level low motor neurons. And because all of the fibers have been compromised here, no more modulation is possible at T10 and also below the level of lesion. So what happens to the lower motor neurons which are at the level of T11 or T12 or L1, what they will be doing? They become free to fire frequently. They become free to fire frequently. Why they became free to fire frequently? Because their control by upper motor neuron, which was plus minus modulation, is gone. You have compromised all the axons here. So there is nobody to modulate you and they become free to fire frequently. What will happen when lower motor neuron is free to fire frequently? Lot of acetylcholine. And when you give a lot of acetylcholine to skeletal muscles, what the skeletal muscle will do? What is this? Flexion deformity in upper limb, extension deformity in lower limb. What is that? That is hemiplegia, spastic paralysis. So in Brown-Séquard syndrome, at the level you have flaccid paralysis, but below the level of lesion you have spastic paralysis. Let me give you this diagram only, which you have in your exams. You know this. So in this type of question, because again they are very frequently asked questions, very frequently. I have seen last 5 years at least they are asking. So in here you can see for yourself at the level, because this is injury at T10, right side, right T10, right side T10, spinal cord is compromised. There is hypotonic paralysis at the level of T10 muscles, but then there will be spastic paralysis below the level of lesion. So element type of palsy at T10 and human type of palsy below the level of lesion. But do you really understand why it is happening? That why is important, that concept is important, and I am just trying to make you understand that this is how you should approach your exams. I have seen most of the faculty, I watch them, I watch all of them. Whoever is in the field, I watch all of them. I have seen them, they are not serious. Because they themselves are in the top 10 in the society, they have achieved some success, but they are not training you properly, and that is a tragedy. Can you tell me why there is contralateral loss of pain and temperature, and that to 2 segments below the level of lesion? Because it is written by Harrison medicine, pain temperature which is carried by free nerve ending. Fibers will enter, ascend 1 or 2 segments before the pathway crosses and start moving on the other side to reach the cerebrum contralaterally. The pain and temperature fibers which are free nerve endings, they enter, say for example T12 fibers, T12, skin T12. From T12 skin the fibers will enter, go to T11, T10. At T10 they will synapse, cross and start moving up towards the cerebrum, contralateral cerebrum. Now the lesion was at T10 spinal segment. Which fibers you have compromised? you have compromised T12 fibers from the other side. And not only T12 fibers, whichever fibers came from below T12, T12, L1, S1, whichever fibers, they were all bundle of axons which were running in the spinal cord on this side have been compromised at T10 level. That is why the loss of pain temperature is contralateral, because basically the pathway which we are talking about is called spinothalamic tract, specifically lateral spinothalamic tract. So in Brown-Sequard syndrome, hemisection of spinal cord, the lateral spinothalamic tract has been compromised, and it is always running contralateral, so problem will be contralateral. 1 or 2 segments below the level of lesion, because these fibers, before they actually cross, they ascend 1 or 2 segments. So 1 or 2 segments below the level of lesion, and entire body below the level of lesion will be having loss of pain and temperature. Why the loss of sensations which are carried by the dorsal column, medial lemniscal system? The dorsal column, medial lemniscal system carry 5 sensations. Which 5 sensations are carried by dorsal column, medial lemniscal system? Pressure, tactile discrimination, vibration, stenosis, conscious proprioception, those 5 sensations. Those 5 sensations which are carried by dorsal column are lost on the same side. Why there is ipsilateral loss of 5 sensations carried by dorsal column same side? Because even dorsal column, which is fasciculus gracilis and fasciculus cuneatus, this is dorsal column, that was compromised, and whatever, maybe the Pacinian corpuscle carrying pressure or Meissner corpuscle carrying tactile discrimination from right side. So right side, tactile discrimination, Meissner corpuscle, pressure vibration, the Pacinian corpuscle from right side. The fibers were running ipsilaterally before they cross in the medulla oblongata, brainstem, before the pathway crosses to continue as medial lemniscal system. Medial lemniscal, this is dorsal column, medulla, then it is medial lemniscal system. So dorsal column, medial lemniscal system, the first part, the first degree neuron pathway, dorsal column or fasciculus gracilis, if it is damaged on right side, the problem will be right side. So most of these sensations are lost on the same side except pain temperature and crude sensation. The crude sensation is lost on the other side. Crude sensation means touching with cotton. Crude sensation, touching with a pencil tip is fine touch. Tactile discrimination. Tactile discrimination carried by dorsal column, whereas crude sensation, touching a wide area like touching with cotton, that is crude touch. That is carried by anterior spinothalamic tract. And spinothalamic tract is almost always running contralateral when it was damaged here. So not only pain and temperature, but also crude touch sensation will be lost on the opposite side, because spinothalamic tract may be anterior or lateral, it runs contralaterally. If lesion is on the right side, problem will be on the left side. Brown-Sequard syndrome. Though, as some teacher was telling, you have been reading Brown-Sequard syndrome from your first year MBBS. What is there to teach? What is there to learn? Wrong approach. You should not tell this to the student. This is wrong approach of telling this all to the student. Maybe they are reading. But why the examiner is asking it again and again? Because they must be answering it wrong. Questions will repeat again. Take it from me. Questions will repeat themselves only if the students were answering them wrong. The moment students start answering it correct, questions will change. Their depth will be more. They want wrong answers from you, isn't it? Out of 100 people, 95 people should give wrong answer. Otherwise, what is the use of conducting exam? So any topic which repeat is dangerous, take it from me. And any teacher telling you, what is this? This is a repeat topic. I'm teaching you all the time. No man, you're not teaching it properly. That is the problem. Anyway, I'm not here to comment upon other people because I myself am not perfect. How can I comment upon other people? People will always be imperfect. Even But it is for your purpose. It is a cutthroat competition. No, don't take life easy. Okay. Right. So let us move further and see. This is another topic which they continuously keep asking. And what are you looking at right now? Your eyes must be trained, magnified, still magnified. So I think you can immediately find out what is this. Tree-like appearance, the white matter, if I draw it here, the white matter, this is white matter, branching pattern, what you say, arbor vitae, the tree of life, cerebellum. Now, cerebellar cortex, 3 layers. You must have seen this question is persistently asked. Why they are persistently asking it? Either you are unable to understand the question, giving some wrong answers, or why this question should repeat itself so many times. So in the cerebellar cortex, you will have 3 layers, and as you see, outer is molecular layer, middle is Purkinje layer, and then there is innermost granule layer. In the molecular layer, which you have magnified here, you will have SV cell, which is the stellate and basket cell. In the cerebellar cortex, you will have 3 layers, outer molecular layer, middle Purkinje cell layer, innermost granule layer. In the molecular layer, you will have stellate and basket cells. Stellate means star shape, basket shape. Stellate and basket cells, you can remember SBI, State Bank of India, SBI. They are inhibitory to Purkinje cell. This is Purkinje cell giving dendrite into molecular layer. So this is the middle layer, the Purkinje layer, and the middle layer, Purkinje layer, is sending some dendrites into the outer molecular layer. Stellate and basket cells are inhibitory to Purkinje cells. Stellate and basket cells, which are in the molecular layer, are inhibitory to Purkinje cell, and Purkinje cell is inhibitory to, comes as a question. So Purkinje cell will be inhibitory to deep cerebellar nuclei, for example, dentate nucleus of cerebellum. For example, dentate nucleus of cerebellum. I'll repeat again. In the outer molecular layer, you have stellate basket cell, which are inhibitory to Purkinje cell, and Purkinje cell itself is inhibitory to deep cerebellar nuclei like dentate nucleus. They use a neurotransmitter which is GABA, gamma amino butyric acid, GABA, which is inhibitory neurotransmitter. And from there we have learned the pathway also, dentato-thalamic tract. Dentato-thalamic tract. This all pathway is concerned with the coordination of voluntary motor activity. That is a function of cerebellum. Now in the molecular layer you have stellate basket cell. In the middle layer you have Purkinje layer. What about the innermost layer, which is granule layer? Granule layer will have granule cell. And along with granule cell there is one more G, Golgi cell. So what you can remember is that in the innermost layer you have GG cell. And what is this GG cell? GG cell is, one G is granule cell and the other G is Golgi cell. G cell, the Golgi cell, and the other G is granule cell. Now there is a lot of information here, but let me just focus upon the information which the examiner is focusing himself and preparing some questions. So as you draw this pathway, you are asking one person to walk in a straight line, and he is moving his right lower limb to walk in a straight line. As there is a change of position of right lower limb, that change of position, proprioception, is carried by dorsal spinocerebellar tract. This is right-sided. So because I am moving my right lower limb, so there is a change of position of right lower limb, right-sided dorsal spinocerebellar tract is carrying the information. That information is mossy fibers. And these mossy fibers, they use inferior cerebellar peduncle to enter the cerebellum. So dorsal spinocerebellar tract, because it is passing through the spinal cord into cerebellum, same-sided cerebellum ipsilaterally. It is ipsilaterally. So it goes ipsilaterally, same side, entering the same-sided cerebellum, because cerebellar controls are ipsilateral. If there is a lesion on the right cerebellum hemisphere, problem will be on the right side only. Right lower limb will not be able to use it properly for walking in a straight line. So right-sided dorsal spinocerebellar tract is creating mossy fibers, and these mossy fibers, they synapse in the granule cell. The granule cell which is in the granule layer of cerebellar cortex. And then granule cell will give some fibers which are running like this. They are called parallel fibers. They are the parallel fibers. And when the dorsal spinocerebellar tract was activating the granule layer, it was positive, means stimulatory. And even the parallel fibers are stimulatory. But what are they stimulating? They will stimulate the rest of the 4 cells. And which 4 cells they will be stimulating? In the cerebellar cortex, we have told there is SBI cell on the outside, there is a Purkinje cell in the middle, and there is GJ cell in the inner layer. This is cerebellar cortex. So if this is cerebellar cortex, I already have sent one fiber, which was the mossy fiber, and mossy fiber was already activating one cell, granule cell. Does that mean the granule cell, which already is activated, will be using parallel fibers to stimulate remaining 4 cells? Yes, remaining 4 cells, which are the stellate, basket, Purkinje, as well as Golgi cell. So once this pathway is activated, all the cells are stimulated. All the 5 cells are stimulated. Yes, all the 5 cells will be stimulated. The first cell, the granule cell, is already stimulated, and it is now using parallel fibers to stimulate all of them. So stellate, basket, or Purkinje, or Golgi, all of them. Yes. After that, then there is some negative mechanism which I told you, SBI. So stellate and basket will inhibit Purkinje, and Purkinje will inhibit the dentate nucleus, which is deep cerebral nucleus. From there it will go to thalamus, and from thalamus it will go to cerebrum. Dentatothalamic tract. So as you say, this is stellate basket now inhibitory to Purkinje. Purkinje is inhibitory to dentate nucleus. That means it is stimulated again, because one inhibition and second inhibition. That means this is minus minus is what? Plus. So it will stimulate the cerebral cortex via thalamus. Yes, because dentate nucleus working on thalamus is positive, and thalamus working on cerebrum is positive. So I am not going into much detail of this pathway, but this is dentatothalamic tract, which will then activate cerebrum, and from cerebrum you will have corticospinal tract. And that corticospinal tract, which will come from this cerebrum, because I have told you the dentatothalamic tract fiber decussate at the level of inferior colliculus. So they have decussated. If I am talking about right lower limb, right cerebellum, which thalamus would have been activated? Left thalamus. Where is this crossing? Superior cerebellar peduncle. That is at the level of inferior colliculus. And then this brain is activated. This brain will send you which pathway down? Corticospinal tract. Move which limb? Right lower limb. And you can put your foot in appropriate place, because you are trying to walk in a straight line. So change of position, right lower limb, right cerebellum is activated, left thalamus, left cerebrum, and from the left cerebrum again corticospinal tract, right lower limb will be working accordingly to place your foot in particular direction. So this circuitry, continuously they are asking. They are asking, where is this dentatothalamic tract decussation happening? Where is corticospinal tract decussation happening? You know, corticospinal tract decussation happens at lower medulla, then only it goes down. So of course there are some repeat questions which are simply repeated. just for the sake of it, because examiner also don't want to make such question paper where nobody can answer no question. Examiner won't make any question paper where nobody can answer no question. It is not like that. You have to give some questions which are simple, which everybody can answer, so that they have some confidence at least. So there may be some repeat questions which are simple, but I always doubt any repeat question to be simple. There was something which the student has missed, because we are not giving exams. Student gives us the question, this type of question came. Maybe the student himself could not decipher the depth of the question, or it's repeat questions are very dangerous questions, take it from me. Now, a question came, it was on basal ganglia, direct pathway. Basal ganglia direct pathway, and I have seen, in fact, no faculty. In fact, what happens is when there is an exam, some students give answers, make videos. Students were giving correct answers, but the faculty who is teaching is not giving correct answer. So the standard of the level of depth of knowledge of student is far much better than the depth of knowledge of the faculty, or maybe the faculty is lazy, don't want to work hard. This is not an anatomy question, it is physiology question, because I teach anatomy, I should not be too much bothered, but I am not like that. I have to read physiology books also, I have to read medicine book also. I have to understand what the examiner is trying to ask. And anyway, when the question is prepared by two faculty, anatomy and physiology sitting together, how can a single faculty teach you the answer? It is not possible. There should be two of them. I should stand with physiology teacher, Dr. Manna should stand with me and then discuss. But anyway, let me just finish it off. Can you tell me the parts of basal ganglia here? Like this is caudate nucleus. This is the caudate nucleus. This is lentiform nucleus, which will have two parts, outer putamen and inner. Inner will be globus pallidus. So caudate nucleus, putamen outside, inner is globus pallidus. Pallidus means paler, light color. And can you see this dark color here, secreting dopamine? The substantia nigra, using dopamine. The question was asking direct pathway of basal ganglia. Question was asking direct pathway of basal ganglia. Though there are very good teachers, I personally can tell Dr. Marwa sir makes his best effort to at least reach the depth of the question and try his best to give you possible answer. At least he tries. There are some faculty who don't even try. That is such a bad thing. So I have read it, lot of things, but to simplify, direct pathway, if you are asking, the question was on direct pathway. So where the direct pathway will begin in basal ganglia? It begins at the level of substantia nigra. I'm not going into much details, just trying to take care of that question. So from substantia nigra, a dopamine pathway will be given, which is called as nigrostriatal pathway, of course. Nigrostriatal. Nigro means substantia nigra. Striatal means caudate putamen. Striatal, nigrostriatal pathway. Using dopamine, and it is excitatory to caudate. So number one, from substantia nigra to caudate nucleus, you are giving positive, which is dopamine. But then the caudate itself is using, say, another pathway on the globus pallidus, which is negative, GABA. It is GABA. So it will inhibit the globus pallidus. And globus pallidus itself will inhibit the thalamus, which is, here. This is the thalamus. So it will be inhibiting the thalamus. Negative. Once again, I'll repeat, the direct pathway of basal ganglia, where it begins, substantia nigra, nigrostriatal pathway using dopamine on caudate nucleus, stimulate it, but caudate will send negative pathway on globus pallidus, which will itself send negative pathway on thalamus. But when there are two negative, what will be eventual thing? Positive. It will be positive. And in fact, now the thalamus will stimulate the cortex. Thalamus will stimulate the cortex because thalamic fibers are stimulatory. So direct pathway is stimulatory. Now, maybe the direct pathway is stimulatory, and in sequence, they were asking, put them in sequence. So what is the first thing? Substantia nigra. What is the second thing? Caudate. Third thing, lobus pallidus. Fourth thing, thalamus. And fifth thing is cerebrum. Fifth thing is cerebrum. Be careful. Though it is understood that what is the purpose of basal ganglia? Purpose of basal ganglia is to smoothen the voluntary motor activity by planning and programming the voluntary motor activity. That is basal ganglia. Basal ganglia is smoothening the voluntary motor activity which is done by skeletal muscles, and planning and programming. For example, putting a thread into needle. If you want to put a thread into needle, it should be smooth. Otherwise, jerky movement. If there's a basal ganglia disorder, jerky movement. So basically, smoothing of movement is done by basal ganglia. But is the movement done by basal ganglia? No. Movement is done by the cerebrum. By corticospinal tract, we were talking about corticospinal tract is the one which controls the skeletal muscle. So whenever there is a thought of doing a movement, say I'm telling you, there on the table there is a thread and needle, put the thread into needle. And you will go there and you see where is thread and needle, the thought will come. That thought is prefrontal cortex. Prefrontal cortex will send it then towards the next system, which is basal ganglia, which will plan and program so that movement is smooth, and then it will send it to the cerebral cortex, which can then actually move the corticospinal tract, corticonuclear tract will help you move the needle and thread. So if you are using direct pathway, then there will be facilitation of this movement. So direct pathway is stimulatory. And in a sequence, they wanted the sequence of answering. Number 1, substantia nigra. Number 2, caudate nucleus. Number 3, globus pallidus. Number 4, thalamus. Number 5, it is the cerebral cortex. But since there are 2 negatives in between, they make it effectively positive or stimulatory. So this is some of the things which is again next type of questions. Maybe it is not a clinical question. I did not make it a clinical question, but can be like that. Now, a question keep coming all the time. Do you really know what is this girl having? It is a basal ganglia disorder. It is a basal ganglia disorder. Tell me, identify which disorder, which clinical, what is the technical term used here? Can you tell me? Parkinson's, athetosis. Tell me, what is this? Yes. Sagar Tonape hemibelismus it is. So you should actually know what see, hemibelismus, how many times this question has come to you? This is the next stage. They will dig deeper and more deeper. So how do you identify that it is a case of hemibelismus? Proximal muscles will be violently moving. Proximal muscles, like shoulder muscles and thigh muscles. So shoulder muscles, thigh muscles, and it is usually unilateral because there is subthalamic nucleus injury leading to hemibelismus, and it is unilateral, violent. You cannot stand in front of such a patient because they'll slap you like this, and it is moving like this. The upper limb and lower limb and proximal muscles are involved. In chorea, distal muscles are involved. In athetosis, distal muscles are involved, but they are slow and writhing. Slow writhing, like snake movement. So if it is slow writhing movement, distal muscles, it is athetosis. Chorea can be jerky, involving, like it will be like this. So that is chorea. This is athetosis. But this is not hemibilismus. Hemibilismus is not distal muscles, proximal muscles. And where is the lesion? Subthalamic nucleus. It is usually unilateral. And subthalamic nucleus is a part of, basal ganglia. Is amygdala a part of basal ganglia? This question comes. Is amygdala a part of basal ganglia? You say yes, amygdala is a part of basal ganglia, but amygdala is more a part of limbic system. It is more a part of limbic system. What is limbic system about? Limbic system is about emotions. So which emotion are you talking about? Fear, emotion of fear. Amygdala gives you the emotion of fear. In Gray's Anatomy, you will find under basal ganglia, there is some heading, subheading, and under basal ganglia, they'll put amygdala. But amygdala is more a part of limbic system. A question comes, amygdala is a part of basal ganglia or limbic system? What is your first answer? Limbic system is a better answer than basal ganglia for amygdala. Amygdala is a part of limbic system, which is related with emotions, memory, behavior, smell, emotions, memory, behavior, Pepys circuit. But remember, in Pepys circuit, there is no participation by amygdala. So amygdala is a part of limbic system, but is not a part of Pepys circuit. Pepys circuit, what do you include in Pepys circuit? In Pepys circuit, you have to start with what is called as hippocampus, the one which is for short-term memory. From hippocampus, you'll have the fornix, reaching mammillary body, which is hypothalamus, and from there it will go to anterior nucleus of the thalamus. This is Pepys circuit. When you are talking about limbic system, emotions, behavior, smell, pathway, and memory, smell, emotions, behavior, this is Pepys circuit. In Pepys circuit, you don't have amygdala, but recently a question came, is amygdala a part of limbic system? Yes, it is, but it is not a part of Pepys circuit. What is there in Pepys circuit then? And take it from me, they are very frequently asking these questions and they'll keep coming again and again. They are repeat questions and they just go deeper and deeper, they dig deeper. Something which we are not teaching or which you have not learned, and so you be ready for this topic as well. So from hippocampus, which is for short-term memory, you want to make it a long-term memory, so you will use the fornix, and fornix will be then sending the information to mammillary body, which is in the hypothalamus, and from mammillary body it will go to thalamus, which is anterior nucleus of thalamus, and from anterior nucleus of thalamus it will go to the cerebrum. In the cerebrum it is the cingulate gyrus in the cerebrum, and from there it will come to hippocampus. It's a complete circuit. Hippocampus for short-term memory, you want to make it long-term memory, use the fornix, and from the fornix it will go to the mammillary body, hypothalamus. From there it will go to thalamus, anterior nucleus of thalamus. This is the mammillothalamic tract, because mammillary body, thalamus. And from there it will come back to the hippocampus via cerebrum, the cingulate gyrus. Cingulate gyrus is for satisfaction, the emotion of satisfaction. The satisfaction could be after having food or after having water. You satisfy after watching a Netflix series also, you can be satisfied. After playing a game, you feel satisfied. That satisfaction in cerebrum. What is the hypothalamic center for satisfaction? What is the hypothalamic center for satisfaction? Say you had food and now you are satisfied. That is ventromedial satiety center, ventromedial nucleus. So ventromedial nucleus of hypothalamus, satiety center. and here in the cerebrum, cingulate gyrus is satiety center, and this is all about emotions, behavior, and smell pathway also comes, which I have not mentioned here. There is a description of smell pathway. See, my point is, I never used to put smell pathway here because nobody was asking. But then I started putting it. Once I started putting it, then they have asked amygdala, which I never teach in limbic system. So any topic which is repeated, you should not just remember whatever was asked. You should go 2 steps deeper to that. And that's what I'm doing here. That's what you should also do. And take it from me, it is not easy. It is not easy. If you are taking it easy, you are mistaken. So we have some 15 minutes left with us. I just wanted one topic to be taken care of. This is the topic. They are giving you some transverse sections. Say this is a person going into CT scan machine and you are looking inferior to superior. That is how all the CT scans are viewed in a transverse section, transverse CT. So one transverse CT has been taken, say for example, this is the way we are looking at it, transverse CT. In here, they put some markers and ask you about the details. Like recently they are asking, what is the arrangement of pulmonary vein, pulmonary artery and bronchus at the lung hilum, anterior to posterior? What is the arrangement of pulmonary vein, pulmonary artery and bronchus at the hilum of lung, anterior to posterior? That can be answered here itself. This is the actual dissected specimen which anatomy people can give. This is the radiology people who can give, and they are the same diagrams actually. So where have you taken this diagram then? We have taken this diagram obviously in thorax, because you can see this is lungs. This is the lungs. Now if these dark shadows are lungs and you are looking inferior to superior, this must be right lung. This must be right lung. So this is right lung and that will be left lung. Now you can see one thing. This is sternum anteriorly. This is vertebra posteriorly. So sternum anteriorly and vertebra posteriorly. So first of all, we have to identify, this is thorax region, lungs are there. This is anterior sternum and this is posterior vertebra. What is just in front of the vertebra? What is just in front of vertebra is esophagus. This is esophagus. Now if that is esophagus just in front of the vertebra, what is in front of the esophagus? And in front of esophagus what you see is one bronchus here, one bronchus here. One bronchus here, one bronchus here. This is right principal bronchus and that is left principal bronchus. So which is the most posterior thing? Vertebra. What is in front of that? Immediately esophagus. What is still in front of that? The tracheal bifurcation. If the trachea has bifurcated, it has bifurcated just now, because the bronchi are very close to each other. Carina is evident. Now if you say carina is evident, this is T4, T5 vertebral level. T4, T5 vertebral level, or the vertebra could be T5 vertebra. This is T5 vertebra because it is T4, T5 vertebra where the trachea bifurcates. If it has already bifurcated, you must be at T5 or maybe lower. But since the bronchi are close, you must be at T5 level. What is in front of that? In front of that, I find pulmonary trunk bifurcating into 2. So if it is pulmonary trunk bifurcating into 2, this must be the right pulmonary artery because you are looking from inferior, this is right. So this must be, like you see, this is, let me use this color, this is the pulmonary trunk dividing, and as the pulmonary trunk is dividing, right pulmonary artery, left pulmonary artery. Pulmonary trunk bifurcation occurs at the same level where you have the bifurcation of trachea, disc between T4 and T5. So vertebra level T4, T5, you have tracheal bifurcation and you have pulmonary trunk bifurcation also. From the right ventricle, you have pulmonary trunk bifurcating into right pulmonary artery, left pulmonary artery. So same level it is happening. Now if this is pulmonary artery, what is still in front of that? That is pulmonary vein. What is still in front of that? That is pulmonary vein. So vein is most anterior, artery is sandwiched, and the bronchus is posterior. The arrangement is VAB. VAB. V, vein, most anterior, pulmonary vein, most anterior, pulmonary vein, most anterior. What is in the middle? Pulmonary artery. A for artery, pulmonary artery. A for artery, pulmonary artery. What is the B? Bronchus. The bronchus is, here it is left principal bronchus, but whatever you have arrangement of VAB on left side, it will be same on the right side also. Right and left, there is no difference. Now why vein is most anterior? Because it has thin wall as compared with artery, which is thick wall, and thickest wall is bronchus. So thinnest wall, most anterior, should not be compressed, and then thick wall, artery, and the most thickest is bronchus. Bronchus is quite thick as compared with artery or vein. So VAB, anterior to posterior. That relation you can see here as well. Now what is this large vessel which is just to the left of vertebra here? What is this large vessel which is just to the left of vertebra here? And this large vessel, the arrow mark is also there, is descending thoracic aorta. Descending thoracic aorta. It is aorta which is descending, and it is to the left side. If this is descending thoracic aorta, then where is the ascending aorta? And ascending aorta is here, to the right side of pulmonary artery. So this is ascending aorta to the right side of pulmonary artery. What is still to the right side of ascending aorta? What is still to the right side of ascending aorta is superior vena cava. This is superior vena cava. Now, how do you know the three vessel arrangement is like this? First of all, the left ventricle sends the ascending aorta like this, which gets sandwiched between two vessels. Left ventricle will send ascending aorta, gets sandwiched between two vessels. A vessel which is coming here, superior vena cava to the right, and a vessel which is coming here from the right ventricle, that is pulmonary trunk to the left. So left ventricle sends ascending aorta, is sandwiched between superior vena cava on the right side and right ventricle sending pulmonary trunk to the left. So three vessel arrangement. What is this? Superior vena cava. What is this? Ascending aorta. And what is this? Pulmonary trunk. What is the most right side? Superior vena cava. What is to the left of that? Ascending aorta. What is to the left of that? Pulmonary trunk. So superior vena cava and the ascending aorta and the pulmonary trunk. Why can't you see inferior vena cava here? We cannot see inferior vena cava here because inferior vena cava is draining the body below diaphragm. Body below diaphragm drains into inferior vena cava, and you are in the thorax. In the thorax, looking for inferior vena cava is very rare chance you will find it there. Of course it is there, but what will be more evident? Superior vena cava. Inferior vena cava is very short length when it has entered the level of lungs. This is the level of lungs. At the level of lungs, finding inferior vena cava is not easy. Moreover, inferior vena cava will not be more anterior. It will be in relation with the vertebra and to the right side. In relation with the vertebra to the right side, and instead of inferior vena cava, if you find a vessel here, there will be azygous vein actually. So any vessel which you find here in relation with the vertebra, first of all, azygous vein is smaller. Inferior vena cava is large lumen, small lumen, large lumen. So first of all, it is not inferior vena cava at the level of lung. Most of the time it is not. And what you find will be azygous vein, which is then draining into superior vena cava. So azygous vein draining into superior vena cava is also at the same level. Azygous vein draining into superior vena cava is also at the same level. Which level? That is sternal angle of Louis. Sternal angle of Louis, manubrium sternal junction. Manubrium sternum junction, that is the disc between T4, T5. So what all happens at sternal angle of Louis? Pulmonary trunk bifurcation, tracheal bifurcation, and azygous vein draining into superior vena cava. The location of azygous vein is close to the vertebra, to the right side of vertebra, and it drains into superior vena cava. So sometimes the section may be where you find that azygous vein is actually going to enter superior vena cava, and that channel is also evident because the section was taken at sternal angle of Louis. Again, these diagrams are very important and they'll repetitively will be asked. This is thorax. They can ask you in the cervical region and in the abdomen region, especially transpyloric plane. So be careful about the transverse section which can be asked at transpyloric plane, which we'll be doing tomorrow when we take care of abdomen region. See, hemimelismus lesion is subthalamic nucleus, chorea, caudate nucleus damage, chorea. And if you say athetosis, athetosis is a basal ganglia disorder. Basal ganglia disorder like lentiform nucleus compromise, athetosis. These sessions can be for FMGE as well, for NEET PG, for USMLE. I don't discriminate between any of such exams, though the levels will be USMLE is highest level, NEET PG is at a lower level, FMGE is still at a lower level, but I teach all of them in the same way. Patient falls on the same side if it is cerebellar ataxia. Cerebellar lesions are ipsilateral problems. Okay, so we'll stop here because I was given 2 hours, 3:30 to 5:30, and I think there is another session which is scheduled. So tomorrow we will continue with our discussion and I'll come again in the evening 3:30 to 5:30. I'm just trying to make sure that whichever topics we are discussing are the topics which are supposedly going to appear in your next coming exam, so that it improves your scoring, because the better the score, the better the merit rank, the better your chances of getting a PG seat in a good college in a subject of your dream branch, whichever you targeting for. And I apologize if during my teaching some people, because I'm not a very sophisticated person, very crude in my methods, so some people might not feel very good, they might feel hurt, and some of them they feel that it is going totally off track. I am never off track. I am a very focused person. You may or may not realize, but I have only one intention, and that intention is to get you into PG seat at the earliest possible. I have no other purpose of coming here standing in front of you. With all my sincerity, that is the only purpose. All the best. Take care.
Subscribe and press the bell icon so you never miss an update from PrepLadder. Subscribe and press the bell icon so you never miss an update from PrepLadder.